So let's look on the surgical treatment. So surgical treatment, this is not correct place to say it, because, really everybody knows it, that it's not that much about cartilage. It's about all around patella and all around the knee. It's all about the instability correction. It was about unloading. It's very much not about cartilage. But as far as was asked about cartilage, and David kindly asked me if it really exists, it exists. And there are some possibilities to restore the cartilage, which are different possibilities coming from autologous chondrocytes. I don't know if you still have autologous chondrocytes in France. In Italy, no. In Germany, for example, yes. But when you have scaffolds, you have combined with microfracturing or without microfracturing. You have particulated cartilage, autograft or allograft. You have orts. You have also allografts, basically very largely used in the United States. So let's look on what we have on the evidence. And this is the systematic review when you have 42 studies, which are basically quite a lot, but there are absolutely no randomized controlled trials. And most of the studies are dedicated to chondrocytes, which was basically not the method we are using now. Most of them, somehow show you the promising results and somehow giving you, like some tips and tricks, but there are no definitive conclusions of the best surgical approach, because there are a variety of different surgical approaches. I listed them, all of them, and also the patients are the sort of salad of different type of patients, which, We'll look at this later. Just show you a couple of slides with our experience. This is the most long-term study we have, which was autologous chondrocytes, 10 years of follow-up. And if you look on the population, patella patients was doing worse respect to the trochlea, with the multiple lesion worse, and worse females, worse if they required alignment procedures, and they have high BMI, which is basically our patellofemoral patients. So our patellofemoral patients, we know that they go worse. And the cartilage procedures, but here you have all pulled together, realignment procedures, unloading procedures, cartilage reconstruction, all together. This is a little bit more clean study, which is only patella. There is no trochlea. We done together with Stefano Zaffanini. And here it was different scaffold, which is chitosan-based scaffold on the patella, with rather not bad improvement, like 70% of feeling on the MRI, negative. And once again, females are not performing that nicely. This is a scaffold, which is nanostructural scaffold we are using for cartilage reconstruction on patella. Normally what we use this one. Just to show you, this was mostly degenerative lesions, and they performed quite well. Once again, worst outcomes, females, realignment, combined procedures, all other patients. So all this, and I can continue. I will have prepared this presentation and put another, this is our studies, but I put another 10 studies from different groups. But at a certain moment, I look at the presentation, I get terribly bored. You're not bored yet? Yeah, I was. Because, 20 patients, 12 patients, more or less, we can't say something, not really, it's not inconclusive, it's not conclusive, And then I get lunch with Liza Arendt yesterday, and we start talking about discussing what you need, cartilage reconstruction, what you need. And she made me think about, and say, okay, I come back and totally changed my presentation. Because I say, okay, this is okay, I'll just show it with procedures. But what you really probably need to tell you is how what the lessons into all my life of treating cartilage patients, what I can say. Maybe it's just a personal opinion myself of Liza, just discussion, but just to think about, which is more interesting than showing you the different studies and numbers. So first thing, no patellofemoral cartilage reconstruction can be, because trochlea is dramatically different as a result. So trochlea, it works really well. Cartilage reconstruction on trochlea most of the time works, like on femoral condyles. The same outcomes. Totally different from patella. Patella works much worse. Look at this example. Young person, OCD, central OCD of trochlea, nice reconstruction with a coral implant after you see. After 2 years of follow-up, you have really nice cartilage, which is even rare to see with the scaffolds and rare to see with the technique. So it's very favorable case. But if you look on the patella, you never see these things. It's very real. So trochlea is different animal. Like looking on the patella, location matters. Because locations means etiology. It was discussing. This is a slide from Liza. Acute lesions and the cartilage lesions most of the time occurs on the medial facet. And degenerative lesions mostly occur on the lateral facet. Why we care so much? Yes, because this location, as you can see on the slide once again from Liza, it's when you associate it with MPFL or associated with acute dislocation, we have 20% of cartilage detachment, mostly from the patella, which we have to treat somehow. Just don't leave it alone, because it's very young patients with a cartilage defect, so we have to think about it. But when you come to the treatment on the lateral side, you have a possibility to unload the lateral side, which is rather easy, relatively easy to unload, and you have a good clinical result. When you try to unload the medial size lesion or the central lesions, it mostly doesn't work. You have bad results. And here you really don't know what to do. And here you have to start to think about probably reconstruct cartilage lesions. That's why most of the cases of the cartilage reconstruction are on the medial side and not on the lateral side, which a majority of degenerative changes are. So what does it mean? Does it mean that we don't need to reconstruct the cartilage at all? Probably on the lateral part of most degenerative changes, no. Probably we don't need. But when we have focal lesions, when you have medial lesions, when you have young patients, I think yes. Because all the biological studies, all the biomechanical studies, and tons of scientific literature showed that when you have a full thickness cartilage defect inside your joint, you might not feel, because cartilage is not innervated. So everybody says, who cares about cartilage? But at the end, it will induce osteoarthritis because it will disturb biomechanical environment. It will disturb biological environment. It will change your synovial fluid. It will change your biomicros assignment. And at the end of the games, if you have a possibility to reconstruct the chondral defect, especially when they are talking about the medial part of the patella, you have to think about reconstructing it. And just, you remember the brother in jail from the first slide? Just don't forget that you still loves him, and not even if you don't want to talk about, you still loves him. Thank you very much for your attention.